just the last few people, can we please have you seated? Okay, good evening, everybody. On behalf of Dozee, I welcome all of you for a very special evening. I also welcome all of you all online who are watching us live right now. To kick things off, I'd like to invite on stage Professor Dr. Ravi Mahajan, Dr. Kunal Sarkar, and Dr. Sudhir Vinamala, along with our co-founders Mudit and Gaurav, to please light the lamp.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Thank you, sirs. To kick things off, I'd like to now invite on stage our co-founder and CTO with a loud round of applause, Mr. Gaurav Parchani.
Welcome everyone. A very warm good evening. I can feel the energy. A lot of you have been here since the beginning of the day. And I think the energy is palpable, right? The way they say it. So without further delay, on behalf of the entire Dozee family, a very warm welcome to all the healthcare leaders from all the India's leading hospitals right in front of me, friends from the media, and all my dear Dozeans and global partners that have made the time to spend with us today. This day, 9 years ago, Dozee was born with the vision of saving 1 million lives. From a bunch of sensors and algorithms, from a couple of guys and a couple of dogs in an office, to monitoring 1 million patients in the last 3 years, we've come a long way. Today, while we celebrate our journey, it is also very important to strengthen our resolve for the way forward. The way ahead that leads to the most impactful global health AI company in the world. The way that leads to saving 1 million lives and putting India on the global health AI map. We have a power-packed evening today with 2 big launches, and I want all of your attention to tune in for those. We also have some amazing addresses and panel discussion from some of the healthcare leaders on very, very relevant topics today on how monitoring and early warning systems can actually save lives and how to actually implement them as well. But before we go ahead, and before we move forward with today's program, and before I declare everything open, we really want to present to all of you the spirit of Dozee. And for the first time in public, we've already seen a glimpse of it in the first of the day, but for the first time in public, the Dozee anthem. Can we have the Dozee anthem, please?
सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत्
नेता कुछ कर दिखलाए एक ऊर्जा से विश्व जगाए युवा का पात्र ऊर्जा ले आए भारत का गौरव बढ़ाए निश्चल समर्पण से केसरिया रंग ले आए शो हो जाए अल्बर्ट हेल्थ आए Dozee बैंड शो हो जाए हेल्थ आए
on a mission of zero code blue. It ought to take the best in me and you. Na dare, na ruke, na jhuke, na thake. Jab tak we saved 1 million lives. Shiv ho jaye, har bed, health aaye. Dozee bed.
For those of you who don't know, the credit to lyrics of the Dozee anthem actually goes to our CEO. Our beloved Mudit wrote the lyrics of this song on a flight to Singapore. So a 3-hour flight is enough for our CEO to write such an amazing anthem. Imagine what he could do on a flight to the US, which he's already doing. All right. Okay, so to kick proceedings today, we are going to have some amazing addresses, talks, and also panel discussion that I'm personally looking forward to. To kick things off, we will begin with technology, particularly digital health technology, and a talk on healthcare, a digital perspective. Can I please invite to the stage Mr. Vikas Arora, a dynamic leader with extensive experience across several key areas at Google. Over the years, Vikas has contributed to Google search verticals, developed machine learning applications to tackle complex business challenges, and engineered cutting-edge image compression algorithms. He has also played a pivotal role in building the natural language understanding core stack for Google Assistant, enabling seamless voice interactions for the smartphone queries. Currently, Vikas is at the forefront of driving Google Cloud's GenAI initiatives, improving data quality and optimizing business processes across cloud sales, marketing, and enterprise data. An alumnus of IIT Delhi, Vikas brings a wealth of knowledge and expertise to this stage. Really looking forward to this, sir. Please.
Can you hear me? Yeah. First of all, congratulations to all the Dozee family for the 9th Dozee Day. And it's just been a privilege for being here, to having been called to actually give you a small talk. I'm no healthcare expert, so I think probably a good idea for me to come up front so that if I mess it up, then at least there are experts out there who can take care of things. Is there a clicker here somewhere? Okay, so I thought I will just give you a perspective on how we at Google think about healthcare. I know 15 minutes may be too short to talk about everything that we do. Thank you so much. But just wanted to give you a glimpse. I know you guys are already into AI. Today is the Health AI Day. And so I won't be probably talking to people who don't know some of this stuff. But it's just too good to share what we have been doing as Google in the field of healthcare, and hope that will be useful. So Google Health has always been a cornerstone of what Google has been doing for several years now. And if you go by what, I don't know, this is, in fact, Sundar's made always a big commitment to health. And that's been evident through all of the things that we've been doing to be able to deliver on this promise to provide tools to increase knowledge, success, health, and happiness. Whether you look at the search product that we have and the partnerships, and we have some partnerships actually in India as well on what we call knowledge graphs, to actually give qualified subject matter level information to people who search for healthcare information, or with the content partnerships that we have on YouTube, we actually have specialized talks and a lot of content there, again for consumption, both by providers as well as subject matter experts, or with whatever we are doing with the sort of the wearables that we've been doing on the Android platform, and with the partnership on with Fitbit as we amalgam them into Google. So there's been many things, and today I thought I'll give you a little bit of a perspective on what we've been doing in the more recent years and what to look forward to. So we think about, and today is a Health AI Day, so it's probably appropriate to talk about this. There are really 5 AI advances in healthcare as we think about it. And those are areas where you have AI-based diagnosis. In fact, I have a video right in the end of this session of work that we're doing at Apollo, and what we are actually doing in this area in particular. Then actually remote patient monitoring, and of course this is really what Dozee has been championing. And again, this is a huge area, and you guys are the pioneers for how do you bring remote patient monitoring and AI together. Robotics has always been an AI foundationally driven field, and surgical robotics just takes that forward, and this is another area that is actually growing in leaps and bounds. Drug discovery is an interesting one, and really where it's about molecular research. In the old days, and I shouldn't be calling them old days, but it would take anywhere like 10 to 15 years to actually discover a drug, and sometimes the failure rates could be as high as 95%. And how AI has actually been transforming that space into molecular research and accelerating that space so that you could actually make drug discoveries faster with a better success rate. And then, of course, this new extremely promising area that is now showing up, which is really into personalized medicine. And I think we're going to see a lot of work that is going to get done in these areas, especially in the area of personalized medicine, as we actually go forward. Now, there are 3 factors that have been underlying some of the use cases, some of the areas in which AI is actually providing tremendous benefits. And when you look at these 3 things, there are 3 things that are actually creating or enabling this transformation. Number 1, deep learning has really matured. As we have been building models on AI, and I'll talk briefly about what we've been doing with the models. Today, we've got models which actually provide accuracy of in excess of 94 to 95%, which is quite unimaginable in what it used to be about 3 to 4 years ago. And this whole field has actually become very advanced. What you need for running AI, and you know this better, is actually having this localized compute power, which is huge, and especially tailored for running AI models, which is what we call GPUs. And now they are actually being made available, even locally. In fact, we've just launched something where we actually have GPUs on a machine that can sit inside a data center. And then this is really where a lot of work has been done in the last few years, and I'll talk about some examples of what we have been doing in the field of open source data sets as well. Because that's also been one of the challenging fields. Where do you get data all in one place and in sufficient quantities so you could actually run credible AI models on those? So these three, we believe, are underlying reasons why AI has been making such a phenomenal difference to the world of healthcare. Now, if we think about AI, I think the discussion does not complete today unless we talk about what is called generative AI. We've seen the GPTs, we've seen Gemini, and a lot of these things that have come out in the last 1.5 years that have actually brought generative AI to the fore. And as we think about generative AI and taking them to different industries, these are some of the use cases that we actually find in the healthcare industry on generative AI. On one hand, this is about patient-consumer engagement, where providers today, when they struggle on actually managing or engaging a health-aware, a health-conscious, sophisticated patient, or having to deal with patients who are actually in very remote parts of a geography, this is really where patient-consumer engagement can actually be made much richer with the use of generative AI. There are many use cases here, and obviously, it'll take much more than a few minutes to go through that. Clinician and care team support. In COVID times, we saw how much stress it created for healthcare professionals when actually we moved things to remote, and how this care team support and clinician support became an important area. And today I find it extremely encouraging and assuring when I go into to providers and actually seeing AI benefiting clinicians as well as they engage by doing many tasks that usually would consume time and take time away from actually taking care of patients. Research and development, we spoke about that, and we'll talk about a little bit as I go further in the presentation. And then this whole thing about Global South and the kind of clinician-patient ratios that we have. On an average, we have about 16 to 17 clinicians on a population of 10,000. In the Global South, that factor becomes 2.7. Now, that's the kind of gap that essentially exists in global public health that, again, AI seeks to address. And one of the examples is how do you drive large-scale campaigns on global health, especially during pandemics or otherwise, so that you actually have a reach without actually having the kind of ratios that are there in the developed world. So those are very important use cases that we see in which a lot of work is being done. I thought I'll take an example, a small example, and I know that we've got some practitioners here from Manipal. We recently did this work with Manipal hospitals using generative AI, where the challenge really was that as patients would come out, they would face delays in medicine delivery, and then how do you actually build an AI-enabled e-pharmacy applications is really what the solution was, which is powered by generative AI. And if you look at the right, I'm hoping that, yeah, if you look at the so there's really the, in fact, the application actually does exist, where you could actually take handwritten sort of prescriptions, have the app decipher those, translate them into real, simple English summaries, generate automatically cards of whatever, medicines have been prescribed. If this demo was working, you would be able to see some of those things that it seeks to show. And it actually makes the whole experience of an exiting patient really, really seamless by the use of generative AI. The other thing that I wanted to briefly mention was the work that we've been doing in the field of large language models. So we actually had MedPalm, which was actually in 22, and we recently came out with MedPalm 2, which actually has a 85.4% passing ratio. The 60% is a passing ratio for a medical exam in the US. There's a combined medical exam, called MedQA, which actually brings in US and China, medical exams together. And a lot of work has been done over the last few years running large language models on how much do they do. So MedPalm actually succeeded to pass it with 60%, and then MedPalm 2 actually took it further at 85.4% as far as, so these are really, really knowledgeable models that are out there as assistive technologies, not replacement technologies, for healthcare practitioners in various areas and fields. Now we've actually come out recently with MedGemini, which is again takes this whole paradigm even forward, and this one actually just recently scored a 91.1% score on the MedQA benchmark, and this is really the one that we've now just made available. Just one more thing, or maybe a couple of more things that I wanted to talk about. This is another research project that Google has been participating in. It's called Connectomics. It is essentially an AI-based study project that we are working with many educational institutions, Harvard being among them. And this is really where we've actually created data sets of how brain connections work. And today, this is really where so 3D modeling of how brain connections work has been one of the impossible problems that practitioners and research professionals have been working to solve for a long time. But what we did in partnership with many of the large healthcare institutions and universities, we were able to actually put together this project which is called Connectomics. Read it up if you have time. And today we have one of the largest data set at this resolution, 1.4 petabytes, 16,000 neurons, 150 million synapses. These are probably the biggest maps of human brain that exist to be able to help in human brain research. And again, this is most importantly stuff that is open source now. So this is actually available for research organizations around the world to look at. Now, this is another project that's actually made a lot of big impact, and that's AlphaFold. And again, this is one of the projects that has been an award-winning project from Google. We recently came out during 2024 with what we call AlphaFold 3. Now, as we all know, unfolding a protein structure is a very huge task. Normally, there are about 200 million known protein structures that we know of. And in the earlier days, it would take any researcher close to 4 to 5 years to actually unfold one protein structure. And that would what a PhD would do. What AlphaFold did, and this is the third version, is all the 200 million protein structures have now been unfolded and now available as open source. So today, AlphaFold database has actually every single known protein structure, and there are 200 million of those, unfolded, and their structures actually now open source so that researchers could now, and this is a field that is actually becoming very important in the area of personalized medicine, as I was talking about earlier. And this is again a project that at Google we are very, very proud of, and something that actually is solved one of the biggest problems that existed of unfolding protein structures. Lastly, I'm going to just leave you with, and I hope this video works, is what we're doing with Apollo. Again, in the case of in the remote health.
ખેતનું કામ કરે છે અને પશુપાલક સાથે કામ કરે છે એટલે અમને ખાંસી આવતી હતી અને અંદરથી શ્વાસ પણ એમ સડતો એવું થતું હતું અને શક્તિ કમ પડતી હતી, વજન ઘટી જતું હતું, ઝીણો ઝીણો તાવ રહેતો અમારે, આમાં તકલીફ બહુ થતી. અમારું પશુપાલકનું અને અમારા છોકરાનું અને અમારા પત્નીનું આ પાછળ શું થાય એવું પછી અમે રિપોર્ટ ઘટાડ્યો નજીકમાં ધાનેરા જઈ. ધાનેરાવાળા ડૉક્ટર કાંઈ રિપોર્ટ બતાવ્યો એટલે ધાનેરાવાળા સાહેબે કીધું કે તમારે આવી રીતે છે આમાં કે.
My name is Dr. Srinivas Raju Kalidindi. My father was a doctor. He was the only physician for the entire village. But all he had was a stethoscope and a microscope. There was no technology of any kind. So he saved a lot of lives. So that is the reason in my decision to become a doctor and also become a radiologist. India is a country that has about a quarter of world's TB burden. Approximately 1.3 million people died of TB in 2022. Under 400,000 were deaths in India. Good afternoon, everyone. So I'm going to be talking today about TB. TB is an airborne disease. It enters the lungs and it can cause infection within the lungs. It can cause cavities, it can cause abscesses, it can cause accumulation of fluid around the lungs, and it can spread to other organs, and in some cases can be fatal. If TB is treated promptly with medication, the lungs can become healthy again and the patient will be cured. It is not acceptable for a curable disease to kill so many people in the modern age.
I've been at Google now for a long time, over 16 years, and for the last 6 years I've been working pretty much exclusively at this intersection of health and AI. We've been partnering with Apollo Hospital and Dr. Raju and his team for several years now. We have an effort in the use of AI to detect tuberculosis from chest x-rays as a means of triaging. We need solutions that could be scalable and are cost-effective so that you could then detect tuberculosis early enough and thus reduce the spread in communities. And for the case of AI for chest x-ray solutions, it felt like a great fit.
One really good example of how AI can be used is having a van going into the villages with an X-ray machine on board. The patients can come, have a screening done, and then also have their X-ray done. And the X-ray will then be transmitted to a central location where AI can give an immediate interpretation about the likelihood of TB. And this interpretation will later be confirmed by a radiologist. It will act as an aid to the radiologist so that they can make the diagnosis more quickly and more effectively.
અહીંયા ગામમાં મળતા સુધી સગવડ એટલે અમારે આગળ જવાની જરૂર નથી, જલ્દી અમારું નિદાન થાય.
My father had a lot of patients who had TB. If he had access to something like this, I'm sure he would have been able to treat a lot more patients with TB and probably save a lot of lives. My father would have been extremely excited.
Best.
Mr. Arora, thank you so much. I request Gaurav to please come and give a memento to Mr. Arora. Thank you for being with us today evening.
Thank you, Gaurav. Thank you so much. Best. Thank you.
Sarve bhavantu sukhina. Sarve santu niramaya. Sarve bhadrani pashyantu.
Our next speaker, or let's say our chief guest, is a special one today. Although our chief guest needs no introduction, I will still give it a shot. Please welcome Shri T.V. Mohandas Pai sir, an iconic leader and a visionary in India's business and governance landscape. Currently the chairman of 314 Capital and co-founder and chairman of Aaron Capital. His remarkable career spans over 4 decades, impacting areas as diverse as finance, IT, corporate governance, education, environmental conservation, and venture ecosystem. Sir, you are an inspiration to each and everybody in the room, and particularly I can talk about myself, because when me and Mudit began Dozee, you were our idols, and you are still the person that we look up to build a large business and to transform large digital landscapes in India. and not just in India, but for the globe. It gives me immense pleasure, sir, so please call you on stage, along with our CEO, Mudit. And Mudit, if you could please present a memento to sir as well and welcome him as well.
Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani pashyantu, ma kashchit dukh bhag bhave.
Sir, when we were building Dozee, the example that we would often give is that a bunch of people started an iconic company that changed the landscape of IT in India. You were a foundational part of that company, and that has always been inspirational to all of us, and that is at the core of what we are trying to build or trying to emulate with Dozee, and I hope we are as successful as Infosys is. So sir, please, without further ado.
Mudit and team, thank you for inviting me. Folks, this is possibly the first time that I got some memento before being asked to speak. It's a new experience. Thank you very much. I like Dozee for various reasons, and let me explain. Humanity faces a very big challenge today, and that is a declining population in many parts of the world and a very aging population. Let me give you some data. We have 8.2 billion people on the planet. 25% of the world's population is shrinking. Last year, China shrank by 2 million people. Japan is shrinking by around 1 million people. Add to that Russia, Southeast Asia, which is not growing. Fertility in Korea is about 0.9, I think now. And then you look at Italy and Europe, Scandinavia, 25% of the world's population is shrinking. And if you look at population projections for India, Tamil Nadu could start shrinking by 2035. The whole of the south has a fertility of 1.7, and fertility for Bengal and I think Punjab is about 1.6. In Punjab, of course, the boys want to go away to Canada or somewhere else. There is a challenge. And if you look at communities, the Jain community has a fertility of 1.2. In 50 years, I don't know whether there are going to be many Jains around. I'm going to ask all my big Jain, rich Jain friends to adopt some of us. Hopefully, we can get some good money. So this is a challenge around the world, and it's happening for various reasons. The latest data says, globally, I think this year or just last year, the world fertility came down to 2.0, which is below replacement rate. And we are going to see this as people live longer. So people are going to live longer. People are going to age. There are going to be more aged people in the planet than younger people. And in many parts of the world, the population pyramid will be inverted. Actually, the population pyramid for India is inverted. For the last 30 years, we used to produce 2.5 crore babies. For the last 3 years, I think we're producing 2.3 crore babies. In Karnataka, in 2001-2, we were having 12 lakh babies, and now we are having 10 lakh babies. And it's happened because of many reasons. One, general health fertility has come down. Two, of course, people are postponing the age at which they have children. Women are getting very educated. We have about, I think, 950 women per 1,000 men. Out of the 950 women, about 39 or 40 women don't marry. And I mean, don't marry and also don't have babies. And those who marry, I don't know how many babies they have. I don't have the data. I got to study the latest data. So this becomes a global issue. It's good to live longer. All of us want to live longer. But we find in the United States that health spending is 17% of the 17% of the total health spending is on the last 1 year of a person's life. In many parts of the world, as you age, you're kept alive for various reasons. All kind of things go into your mouth and your bodies, and you die a very degraded death, in my opinion. Maybe 20, 30 years ago, people just passed away. They fell sick, they slept, they never woke up, they passed away. They didn't live as long. We live longer because we are healthy. She says, good to live long. Every human being wants to live longer. That's a good thing to have. We are becoming more healthy than ever from the start of civilization. We are living longer than ever. And globally, women live longer than men. So I keep telling my colleagues, don't ever oppress a woman because she'll have the last laugh. She's going to outlive everybody. India too, I think women live up to 71 and men now up to 69. In Japan, women live up to 88, men up to 85. And women live longer because as a species, I think women are built much better and they're more hardy than men, and possibly they don't go through the same tensions that men go through because men do a lot of unnecessary things, I guess. We got to find out all these reasons. Hopefully somebody will do some research. Now, if this is the situation, if people are going to live longer and people are possibly aging, and there are going to be more aged people. For example, in Japan, about 35% of the population is above the age of 60. And that number is going to increase. Even in China, the number of people above 60 is expanding rapidly than people at the bottom because, of course, they had the famous one-child policy. About 10 years ago, the Chinese were having 16 million babies. Last year, they had only 9 million babies. And this is a big challenge because in living memory, we never faced a time when population did not expand. How many of you remember, for the time you possibly grew up, that everybody spoke about a population explosion, everybody spoke about more people. Even today, India, people say India has got far too many people, it's crowded, yeah, but you better be careful because there will not be too many people around in the next 20 years who are of working age. Now, how do you tackle the health needs of people? The only way to tackle the health needs of people is to better technology. Now, technology and medicine has elongated human life. There are many medical discoveries which make sure that you live longer, you're possibly healthy. It costs you a lot of money. That is true. Somebody has to pay for it. And I think that health infrastructure is expanding all over the world. But how do you lead a quality life? And the only way to live a quality life is to use technology. And technology in a manner which is cost effective, so more people can use technology, and in a manner where you can do early detection of whatever happens inside your body so that you can possibly treat it much earlier than before. And you're not surprised about what happens. Another interesting thing is happening globally, and particularly in the United States, is the use of genomics and genetic engineering to elongate life. Today, an interesting thing is that the world has more billionaires than any point of time in history. And all the billionaires have got money, they don't have life. And they want to live longer. And they're now putting a theory that human beings are designed to live up to 120 years. Our lifespan is supposed to be 120 years, right? So I don't know where it comes from, but that's what they say, that are genetically designed to live up to 120 and we wear out. How do you elongate life? So many things are happening. For example, stem cell research, which can possibly rejuvenate some organs for you. And possibly they're looking at triggers to stop the process of aging in your body. I read somewhere that once you're past the age of 30, your body cells regenerate at a slower pace than they did before 30, and the total body cells coming down over time. That is what aging is all about. Now, what exactly triggers that? What exactly happens in a body? We don't know. Maybe they want to push it from 30 to 40 to 50, so the process of aging elongates, and that means people live longer. So technology spending, a lot of money is going there. We don't see it happening in India as much. Our billionaires, I don't know what they're doing, Doc, and I hope they start putting some things. For example, in the US now, they try to take the blood of a young person and renew the blood of older people to make sure the blood cells have got enough energy and the ability to regenerate or get you much more healthy. So in this scenario, technology is going to be the savior, and we need to have many more technologies. Now, AI, like the earlier gentleman said, is going to play a seminal part. Because what AI can do is to use an enormous amount of data to, in a very fast manner, extremely fast manner, to get you results on a scale that you cannot see before. For example, you can use an AI algorithm to look at 10,000 research papers on a particular topic, pick up the key learnings and the key design and create a summary for you. And if you come with a new molecule, you can possibly get it vetted out using an AI. If you see a new compound, you can see that. You can simulate using AI so that the impact of whatever is discovered can happen. And that is enormous because it improves human productivity several times, and it also accelerates the speed of response to any needs that you want. Now, if you look at AI and use the human condition and put all the data there, can you do predictive analysis to make sure that if a human being comes to Dr. Kunal, to doctor here, you know, they can look at him and examine and look at his past history and the data and then find out whether there is a possibility of 2 or 3 of something happening to him, like a heart attack, maybe 2 or 3 months down the line, because they got a huge amount of data by which you can look at patterns. Human beings live on patterns. Everything that happens here is on patterns. Can you see the pattern to see if this pattern happens, this will be the impact 3-4 months' time? I asked Mudit. I'm very curious about Mudit. I'm also getting old. I never know when I need whatever Mudit does. And age is not a nice thing. Age is not a nice thing, you know, because in our mind, you're very young. We want to run, we want to push things, we want to do things in a hurry, but the body does not respond. I remember playing cricket when I was 45. I was a fast bowler. I used to come and run, and they used to hit me for a 6. In my mind, I'm still running fast. I'm throwing the ball, but the ball is just, you know, going on a flight. It's just not moving. But in my mind, it's supposed to move, but it's not moving because the body is not responding, right? As you age, your body does not respond. So I'm interested in Mudit to find out how his data that he collects by putting the IoT mat under people's bed and looking at the 5 vitals can use the data to predict what happens if you have a particular heartbeat or a particular pattern. Are you going to get a heart attack 3-4 months? And Mudit tells me that many lives have been saved because of the enormity of the data. Now just assume that Mudit has 100,000 beds under which his technology runs, and he collects data for 100,000 people over 5 years. Now the entire modeling becomes so very easy, and the modeling becomes very much better, because if you collect data for a person and you see what is happening to him in many parameters, then you can predict and you can treat people and our lives can be better. And just imagine all this data is being collected by a watch. You have the Apple Watch, which does many useful things, or you wear an IoT mat on your body, or whatever it is, and the data goes to my doctor. And the doctor will be monitoring, but the doctor has an alert system where an AI algorithm will give an alert, because the doctor cannot see so much of data. He's busy, right? It will only see when it's exception, and the AI can identify that this is the probabilities and this can happen, and that will be very exciting. That's one example. That's why every time Mohit meets me, I ask him, how many lives have you saved? How much data do you have? How much can you predict? Because I find it extremely fascinating. And I think that is very important for all of us to do. The next thing we can do with technology is to create a digital twin. Let's say that we have a digital avatar for each one of us. The digital avatar is a digital body where all the vitals and everything run in that, and it represents what we have in our physical body. We have a physical body, the blood flows, the brain works, the metabolism works, digestion takes place. Can everything be simulated using all the data that you get? And once you simulate that, you see what is happening. And tomorrow, if you have a drug or if you have something that you need to take to possibly improve your health, can that be simulated on the digital avatar to find out what will be the impact and how quickly it can happen? We just now saw the example where you can take an X-ray and use the X-ray to find out from your lungs whether the small spots, the digital spots that are there in the lung, which are so small, which cannot be seen by the naked eye, what does it portend? What does it mean? I mean, what are the probabilities that it can grow? Can you simulate that looking at possibly some of the data? Because you'll have maybe millions of this kind of X-rays by which you can simulate. And that, I think, will be interesting. Then we can have DNA-based medicine, right? I read, Doc, that about 30% of human beings are mutated and they can't take the ordinary drug. That is 30%. Now, can you use your DNA to analyze which drug is most useful to you among all the drugs? And by doing that, can you give bespoke medicine, which can be done? This can be done using technology. So I just want to stop here to say, I'm very happy to be here And I'm very happy to see what Mudit is doing. What Mudit is doing is critical healthcare, by which you can get all the data of people, you can reduce the cost, make every bed into an ICU, reduce the time spent in the ICU, reduce the strain on our doctors so they can possibly attend to more important things, and also make sure that anything that happens bad to people can be prevented or possibly can be tackled in an easier way. Because we are in a situation where the highest cost for a human being is not good in your lifetime, is not going to be the food you eat or the clothes that you buy. It's going to be your health. And healthcare is expanding at the fastest pace, more than inflation, all around the world. In the US, it is already about 18% of GDP of $26 trillion, and is going up faster than inflation in the United States, in all parts of the world. And in most parts of the world, there's a shortage of doctors, shortage of nurses, and that's not going to be filled up at any point of time more, because those people don't want to be doctors and nurses. And people have to come from the emerging markets, and we are finding that the scope for you to practice is much better in this country. So technology is the savior, and I think we should all look at technology as to how to enhance wealth. So I want to congratulate Mohit and say that how excited we are with being part of his journey, and to tell all of you in Dozee that you're doing a great job, but expand, reimagine healthcare. Using everything that you have, reimagine what is required for a human being, and make sure you do that, and work with all the doctors to see how useful it can be. So using the data and using everything else, you're able to do things much better year after year. Thank you very much.
Thanks a lot, MDP sir. One thing that you can definitely tell about Mohandas sir is he is a man of numbers, right? And trust me, every 3 months, 6 months when we meet, he inadvertently asks me, Mudit, how many lives have you saved? And he asked me, acha 3 mahine mein abhi itna hi bada hai, right? So I have to be on top of it as he is on top of numbers. So thanks a lot for being here. It was such an honor to have you. Big round of applause for him.
Thank you, sir. After that power pack talk, we have to move to the next session. I am looking forward to the next session with a lot of enthusiasm. The next session is going to be a fireside chat. To moderate the fireside chat, please may I call upon stage Dr. Yogesh Kothari. Dr. Yogesh Kothari finished his MBBS from Bangalore University and Masters in Internal Medicine from the Kasturba Medical College in Manipal, followed by Cardiology and Cardiac Electrophysiology. He worked as a senior consultant at Apollo Hospitals. He's presently head of cardiology at Bhagwan Mahavir Jain Hospital and a visiting faculty to premier medical institutions. Dr. Kothari, it's a pleasure to have you on the stage and to moderate the panel today. The topic of the discussion today is going to be Mission Zero Code Blues. How can we prevent code blues from even happening, a single code blue outside the ICU from happening? Now, calling up on my panelists, can I please start with Dr. Sudhir? So, can I call upon stage Dr. Sudhir Vinamala? He's a seasoned consultant in gastroenterologist, hepatologist, and therapeutic endoscopist. Currently leading the KIMS Hospital in Hyderabad as a medical director. He has contributed to clinical research, including notable publications on using a rendezvous technique for closing, please pardon me if I'm getting this wrong, but laryngeoscopical fistulas. So I'm so sorry if I got that wrong. Calling up on my next panelist, can I please have Mrs. Rashmi Srivastav on stage as well? She's the Vice President Group Quality at Narayana Health with over 20 years of experience in operations and quality. Ma'am leads the quality system for all hospitals in the Narayana Health Group. In-depth insight into quality, operation, commissioning, facility management, clinical services have been an integral part in executing various accreditation processes, including JCI, NABH, and NABL. She's a certified professional in healthcare quality from Healthcare Quality Certification Commission, USA, and is a Baldrige assessor for Healthcare Excellence Program. She also holds a patient safety specialization from Johns Hopkins in the USA as well. Pleasure to have you, ma'am, here with us. Can I also call upon stage Mr. Uday Davra? Please welcome Sri Uday Davra, a healthcare leader with about 30 years of experience in the sector. He is the Vice President and Unit Head at Apollo Hospital, Sheshadripuram in Bangalore. His experience in the segment encompasses hospital and consultant management, sales, marketing, business development, operations. The areas of expertise include setting up greenfield projects, acquisitions, turnaround strategy, and more. He is a seasoned healthcare professional with hands-on experience in primary, secondary, and tertiary healthcare. Welcome, sir. Can I also now welcome Dr. Yatish Govindaya. He's the unit head at Apollo Specialty Hospital, Jayanagar in Bangalore. Assistant Medical Director, Karnataka Region, a unit of Apollo Hospitals. He's also president at FANA in Karnataka. Dr. Yatish provides leadership to the unit with responsibility to build 360-degree strategic operation structures. Welcome, sir. Pleasure to have you here. My next panelist is Dr. Sandeep Reddy, infectious disease physician, researcher, epidemiologist, and on all things nice is how his LinkedIn profile reads. Happy to have you, sir, here. Dr. Reddy is a consultant and assistant professor internal medicine. He is the clinical advisor to HICC, AMSP, Ramaya Medical Colleges, and its affiliated hospitals. He is a principle-driven professional with proven evidence-based methodologies and research-oriented clinical practice. An absolute qualified teacher with a demonstrated history of working in higher education industry. He is highly skilled in implementation research, environmental epidemiology, infection control, healthcare management, and public health are his areas of expertise. Welcome, sir. Pleasure to have you here today. Our last panelist for today is Colonel Dr. Anand Shankar. Can I please have you on the stage, sir, as well? Medical Director and Senior Consultant Anesthesiology, Emergency Medicine, and Intensive Care Medicine at Rashtrathana Hospital in Bangalore. Founder and Medical Director, Nima Polyclinic, Dr. Shankar completed his MBBS from AFMC Pune with a distinction in ophthalmology and otorhinolaryngology. He further went to pursue MD Anesthesiology at AFMC Pune. He also holds an EDIC European Diploma in Intensive Care from Zurich in 2014. With an experience over 22 years as an anesthesiologist in various military hospitals, his career has included stints in war-like conditions of Operation Parakram and in counter-insurgency operations of Northeast, United Nations missions in North Sudan from 2011 to 2012. He has led a decorated career in the armed forces and received Chief of Army Staff Commendation in January 2017 and Chief of Naval Staff Commendation in July 2020. We have a pleasure to have you, sir, as well here. With further ado, I would hand it over to Dr. Yogesh to start the fireside chat.
Thank you, Gaurav, Mudit, and the entire Dozee team. And I'm really happy to be here amongst this august panel. And we all know that the most feared outcome or the most dreaded outcome for either the patient or the patient's family is a sudden, uneventful event where there is a life-threatening situation. All of us know that this is the most painful for anyone. And even more painful is having this suddenly and there is an associated panic with the code blue. So we all know code blue has its own panic and the whole hospital is in a toss and there's so much panic created around the thing. And it is very important that the more important is to prevent the code blue rather than deal with the code blue. And with this in mind, I think Dozee is doing a wonderful job. And I think it is very worthwhile to discuss on this AI day as to how we can improve patient outcomes and patient safety and understand how technology can help in preventing these code blues. So let us understand from the panel on various topics that we can discuss. So my first question is basically, what are the various early warning systems? I think any of the critical care specialists can take this. What are the various early warning systems and how frequently they are being used in monitoring the patients in the in-hospital, in the wards? Dr. Anand, you want to, you're from the critical care background, I think.
Good evening, everybody. I'm privileged to be here. Thank you very much, Mr. Mudit and your team. And I wish all of you from Dozee, I congratulate you all for having been here for 9 years. These early warning systems that you're talking about. So in the 1990s, 97 or 98, this started because a lot of people were succumbing to some kind of issues, medical issues, and it was being missed by the medical staff. So in the UK, I think in 1997, early warning scores started, where basic measurement of temperature, respiration, BP, so this TPR, BP, these things were added into scores. So over time, this has developed, and these scores were modified as modified early warning scores. All of these basically help the nurse and the doctors in the on ground to catch a patient who is likely to deteriorate or who is likely to have a problem. It is basically, the idea is not to have a code blue or not to have an arrest-like situation, because these situations tend to become hopeless and the outcome of such code blues are not very good. So the idea is to get, get ahead of this and try to prevent a catastrophic event. So that's how these early warning scores, came up at.
What is the uptake of this course, like in the pre-technology era? Like it was very manual and cumbersome. So how was the uptake and the work on that?
So this had to be done by the nurses at the bedside. They would time to time go to the patient, physically kind of examine the patient, read the data on the monitor, collect the data, and then note it down. And actually analyzing this was very difficult. You could see numbers, but possibly it wouldn't give much information. What is happening now is much better because you have a scoring system and it's happening AI generated.
Dr. Sandeep, we know that the outcomes post-code blue or post-cardiac arrest in out of ICU setting is generally poor compared to, like, if you know in the ICU, if somebody has a cardiac arrest, the outcomes are definitely going to be much better than out of ICU, and at least out of hospital is the first. So how has been your experience? You have been reasonably very experienced in a lot of years of practice. How has been your experience in out of ICU cardiac arrest? Like, what is the kind of data that you have seen? And what is the in general data when it comes to India and globally?
Thank you. Firstly, thanks to Dozee for having us here and putting together a fantastic event like this. Secondly, how many of you actually felt the heartbeat with the Dozee anthem? I could feel it. Congratulations to Mudit on that. And who coined the word Dozeans? I would like to know that too. On that note, let me just start off. Cardiac arrest, or the modified early warning score. The cardiac arrest is a terminal event after a series of parameters that deteriorate over a period of time. So if we have tools and ways to identify it early on, then you have the opportunity to save those lives. That is the key to any modified score. This score has been revised many times. Modified early warning score is the enhanced version of early warning system that Dr. alluded earlier. We also have a pediatric and a modified early warning score for obstetricians. Now, most of the data that we have in terms of the out-of-hours hospital cardiac arrest or the outcome data of cardiac arrest in an ICU setting, it's actually very contradictory data, and the outcome in ICU is far worse because you would have already given them the maximum support needed until that point. So the outcome of a cardiac arrest in ICU is actually worse. There is some data from anecdotal data and actually published data also where MI, myocardial infarction, is the cause for the patient's presentation with cardiac arrest, especially with ventricular fibrillation. The outcome is actually better. That was the reason why a lot of AEDs were placed in the public areas, and a lot of people were trained in the use of cardiac arrest, the ALS and the CPR protocol that we are seeing today. What early warning systems and the data helped us is identifying these deterioration patients early. And as Dr. earlier was mentioning, somebody had to go to the bedside to measure the vitals, which are the pulse rate, respiratory rate, the parameters that we are measuring through Dozee today, had to be charted. And the traditional methodology for doing it was they would measure everything all night and then chart it on a graph. The graphical representation actually gave the insight that somebody was deteriorating prior to the identifying the terminal event. So because now we have something of a remote monitoring such as Dozee, and because we're able to chart it, and because there are models to alert it, I am hoping that today what we're able to do it in a hospital, you would be able to do it in out-of-hospital cardiac arrest too. That's the key thing, I would say.
Yeah, I agree with Dr. Sandeep. Basically, the outcomes of out of ICU, if you look at ward cardiac arrest, I think Dr. Yatish and Uday also will agree, is very, very low, poor outcomes. The mortality is very high. Many times we see wake-up strokes where when we go to the patient, we discover that patient has already developed some stroke some time back. Sometimes we see a discovered cardiac arrest where for 2-3 hours patient has not been noticed and patient has developed the cardiac arrest in his sleep. And the nurses go to check on him and then they discover the cardiac arrest. So many such events are very, very common. Is a very good, bad mix for a hostile situation. So I think more important, as all the panelists are pointing out, is early warning system. I think Sir also wants to add a point, Dr. Anand.
Yeah.
Dr. Anand, please.
Just to put some numbers to what Sir had mentioned, both in India and as globally, the numbers are somewhere between 11 to 26% for out of ICU, but within the hospital, Code Blue survivors survive to discharge. But they've always mentioned that it's a very complex number. Many factors are integrated into it. If it's a treatable cause for cardiac arrest, the survival rate just jumps high. But if it is an asystole, the survival rate just drops down, and then the survivors are very less. But my mentor used to always say, you can throw around these numbers a lot, but for that patient and for that family, it's 100%. You can say your hospital has achieved 40, 60, no Code Blues, but for that one patient and for that family member, it's 100% mortality, and you can't beat around the bush with that. There's an amazing systematic review by the Army Hospital in Delhi. They looked at pre-RMPS, the remote patient monitoring system, and post that. And they've seen an amazing from 23% to 65% survival rate post the implementation of a remote monitoring system. So that's what I think Dozee would bring to your hospital, where your transfer to the ICUs will be more, that you will look at that, but your patients are walking out of your doors safely. So that becomes very important for the end of the day for every clinician.
I think that's a very important outcome measure, and I think most hospitals are striving for that. Dr. Yatish, I think Dr. Yatish, before being a CEO, I think he was emergency medicine physician, I remember, and he has got vast experience in emergency also. Can you throw some light on the diurnal variation? We always see more cardiac arrest, more Code Blues in the night than in the day. What is your take on this, Dr. Yatish?
Yeah, am I audible, right? See, most importantly, first of all, I want to literally thankful to Mudit and the entire team, putting this across. As patient safety advocate, we always look around, go across the world and saying, how can we reduce the mortality rates, or how can we reduce those events, and how can we increase the safety net. When we talk about safety net, in that most important thing, vital parameter which comes across is how closely your patients are monitored. So that is what, literally makes us. We were looking at, so many tools and devices everywhere we go for attending conferences. In attending all these conferences, what is coming out is, yes, there is something is happening, but when it is going to be get applied, that is the question mark we keep on asking. But good thing is, like, thanks to Rahul and Ravi Mahajan are here, like, they put across, stitched the whole thing program quickly, like, and put it across. The minute they said, like, here is something which we want it to be implemented, we went ahead and implemented at all our hospitals at Jayanagar, like, it's currently been, it's been almost 500, more than 500 days. We started in January 16th of 2022, and today we are in 24. So, coming back to your question, like, with due respect to all my nurses, we all know, like, during the daytime, there is intense monitoring. So many people go around and see what's happening to my patients. Those subtle changes, what one need to pick it up, like, we say monitor every 4th hourly at least. People say, like, we want to make the patients to sleep comfortably, and we don't want to disturb their sleep. For their better outcome and care, like, we should not disturb them, not to, sir, patient is comfortably sleeping. And as Kotari wants me to get the answer, like, the answer is codes are more in the early morning hours than in the daytime. So, but we don't know the reason, how to face the family, like, what is the likely cause for it. There is no traces, no trials. So with all these things, as administrators, as medical administrator or the hospital head, we always look at, like, how to own that and how to answer to the family, how to reason out to the family. In that, like, these monitoring devices are very, very useful. And today, thing is, we had, like, I think Dr. Mahajan has got much more data than us. Thing is, just 4 events, I know, like, why it's happened, for what reason it's happened. In one case, the nurse, like, patient said, I don't want to get this disturbance of beep, I want to sleep comfortably. So nurse didn't push herself, like, she put all the pads and watch on the patient side, and we lost that patient. But at the same time, like, when we look at whole piece of things, like, why the data didn't come, it certainly literally helped us. Whenever, like, you've taken a patient onto the cot and the bed, and if the signals are not coming across, we, like, learned that there has to be a trigger, like, why someone is not monitoring this patient. So today we have moved, not just only adopting technology, to why we are not monitoring these patients. Thing is, by and large, the answers are there. That thing is, you need to monitor the patients, due respect to nurses, 24 hours. This device, any format of devices, like, which are really good, saving a lot of life. Kotari, thank you.
Thank you very much. I think you answered the next question also. Did technology enable your EWS course, and how it has helped in improving your patient care? I think partially you already answered. We'll move on to the next question. This is to Dr. Rashmi. Has technology helped in reducing the writing and the other paperwork that the nurses have to do? So much of paperwork, so much of writing, calculations, scores, everything. How technology has improved the efficiency of nursing, and has it led to better outcomes for the patients and safety?
Okay. First, hello. Am I audible? Yeah. So I think, first of all, thank you, Dozee, for bringing me here and taking the perspective of a quality professional into this panel, where you have all the clinicians. So, I mean, coming to the efficiency and the technology reducing the workload of nurses, I think we all are working on that problem, that, we all believe that there's a lot of documentation induced to nurses, either because of quality or in name of monitoring or in name of having a, good care plan. So, but, if I just calculate it average, because we have done a pilot in Narayana with Dozee, and if I just calculate an average time, how much the nurses takes for documentation, for vital approximately, I think 6 to 7 minutes per patient. I think that's the average. I think all of us agree, we take it for every patient. And if one nurse is allocated for 6 patients, then you can calculate that how much in a shift, how much time she is using for only documentation of vital. So, and that also we may not be using it very efficiently, because it has an element of manual error, or we are not getting an accurate clinical data.
But after we started dosing, if I can just say, I was asking my BT team today that I have to go in a panel and can you give me a BT's business transformation team? Can you give me a data how much time the nurses have saved? They were giving me in calculation like for 7 months at more than 1,000 plus hours we have saved for nurses. And that is a really remarkable data, and that's the actual data which we have got it in our pilot. And
amazing. That's amazing.
yeah. And that's congratulations to the Dozee team. Actually, it has helped nurses in reducing their time and using it effectively for care documentation. And if I just take during this pilot, we take the feedback of nurses also. And they are really happy. Because first thing is we are enhancing patient safety because we are getting accurate clinical data. We are building up standard escalation metrics and all. And apart from that, their documentation time is really saved. And the way they interact with the doctors now with the accurate clinical data, it's really good. I mean, the doctors are happy, the nurses are happy. So I think this technology has really helped us, the nurses and the clinical team both.
Add something, sir.
Just taking it forward what ma'am said. End of the day, all the clinicians sitting here is what we care for our patients. So Ramaya did this similar study, time motion comprehensive analysis about how Dozee, it was a comparator with wards with Dozee and wards without Dozee. There was an amazing 45% improvement in nurses going towards patient bedside care rather than with the documentation. But in the end, it's the patient feedback that really matters. So when we looked at the feedback of the patients, the patients on the wards with the Dozee felt that nurses are more with them rather than at the stations. They're with them, asking about their well-being, taking care of their vital health, speaking to them, that empathy going on, rather than shuffling with some notes in the documentation. So there was an amazing 72% feedback from my patients saying they felt better, they've had better quality care from the nursing aspect with the help of the Dozee. So not just doctors or the nurses feeling happy about it, but the patient walked out with a much bigger smile with Dozee indirectly from there.
Thanks.
And I think just to add that, I should not leave my element of quality system. So earlier I used to monitor almost like 10 plus metrics to see the effective results that, whether the early warning score sign is really used, whether the RRT escalation is properly done and all. So those all things, I think we can always have a real-time dashboard and we can monitor through that. Yeah.
Like my experience with this has been amazing. Not only in what we've all spoken, like there is an aspect where Dozee can help in patients because it's a contactless system. So in my clinical experience, I've had patients with 60 to 70% burns, and you cannot tie a BP cuff, their hands are burnt, these kind of situations, there was no answer. And Dozee has come up with a solution where the patient actually is not getting touched.
Monitored.
It's a beautiful system. And also talking about the code blue thing which you were talking about, I was in the army hospital in Delhi, and I was there before Dozee came up. Dozee also got into the army hospitals at a point in time. But we used to have at least a code blue or 1 or 2 code blues every single day. So that would be 20 to 30 in a month, because it's a very big hospital and it's a quaternary care setup. However, once Dozee comes into the into the scenario, all these signs are picked up much earlier, and a lot of patients go to the right place much before they have a catastrophe.
Uday sir, I had a small request. I think Apollo has adapted across all hospitals, and I think a lot of learning has happened from the administrative point of view as to how to overcome this cost the implementation of technology, the billing barriers, the patient billing barriers, the insurance billing barriers, the corporate payouts. So what are the tips if a new hospital is going in for a technology-based early warning system, be it Dozee, be it any other? So how do they circumvent these barriers of finances?
So one is, I think, in the starting, the most important point is the patient care, the patient safety, followed by commercials, which is also important for a hospital to manage. I think when we started, we all had our own apprehensions about it. There's always a resistance to change, to get newer technology, because there are a lot of technologies which have come and not everything has succeeded. So initially we also had this challenge saying that should we really look at it, should we not do it? I'm sure the Dozee team came forward and they said, why don't you try it? And we said, we'll try it for a couple of months. And Mr. Mohandas Pai said, data is the king. Observe it over a period of time. So for almost 3 months, we didn't charge the patient initially. We said, let's do it free of cost, doesn't matter. And then we said, yes, this shows phenomenal results. The number of code blues have reduced, patients have been happy, and a lot of other areas where the nursing teams were happy, the doctors were happy. So we said, okay, let's now start charging. So initially we had this barrier. People would come up and say, I don't know what is this enhanced connected care. I don't want to pay for it. We said, okay, the cost is on us. Don't worry about it. I think we are more worried about your patient going home happily, safely, rather than the cost that I'm going to make, or rather than the profit that the hospital is going to make. Over a period of time, I think we saw the resistance coming down slowly, and the number of no's started coming down as well. We started also billing in our bills to the insurance company, and most of them started accepting it. Initially, they had their resistance, but when we came up, saying that, hey, look, if the patient stays in the hospital, if there's a code blue, he stays in the hospital for 4 days extra, you end up paying much more than what you're actually saving. So they also started accepting it. And today, I would love to say that, all my beds in the hospital are connected to Dozee. There is no exception to any patient. Okay? There's absolutely no resistance. There's absolutely no qualms about making the payment for that. So that's the way I think slowly we took it up. It was not a commercial decision, but it was more of a safety decision for us. And that safety decision really paid off. And I'd like to thank the Dozee team. They came forward. I think that was very magnanimous of their part, saying that, don't worry, if the patient doesn't pay for it, let's leave it aside. And my colleague who's here from Hyderabad, who helped me with the Central Command Center, also said, chalta hai sir, chalne dijiye thode time ke liye. Nahi paisa milega, koi dikkat nahi hai. So we were not looking at money. Our only intent here was patient safety. And I'm sure this is a byproduct that we start making some revenues out of it. So that's a phenomenal achievement that we at Apollo Hospitals found it. Thank you.
Being JCI accredited, I think patient safety is paramount for you, and I think this has helped you achieve that in a better way, I'm sure. Sir, one question I had, it's more of far-side thinking, that do you think with this kind of monitoring available, every ward bed can become an HDO bed? And we have a lot of step-down ICUs, which basically are used for just monitoring of patients rather than any critical care treatments. So whether those things can be converted into more critical beds, because critical beds are always in shortage. So do you think this thing exists in the near future, that we'll do away with most of these HDU beds and be only ICU and wards, because all wards are automatically HDU beds?
Thank you for that. The fact that we're able to monitor patients continuously at regular intervals and identify those deteriorating patients early is what actually you do in a HDU. So if we're able to extract that to all the patients on every ward, then you might have created an entire hospital which is HDU. I think there's no better than that. I'll just add a couple of points to what my earlier speaker said. We had a similar experience. We started with 30 beds, and we said, after the initial pilot, let's see how many code blues we'll have. 60 days, 0 code blues.
Amazing,
okay?
amazing.
And that was how effective it was. We also had similar apprehensions whether insurance will pay for it. And I think Dozee also helped us come up with interactions with the insurance team. Now it is reimbursed by most insurances. so that's not a problem. We tried doing it in two ways. One is selling it as a product, and it didn't go very far. So we said we're going to open up a smart ward. We placed a Dozee under every bed. So for me, my smart ward is my HDU, which is my normal bed. The acceptance of patients is actually far higher than any other ward. In fact, they are willing to pay for it because they are feeling safe that they are being monitored continuously. We've taken that to a step ahead. We've integrated that to a kiosk, integrated that to our HIS and our doctor's application, which meant that the smart alerts which are actually coming from Dozee are on the hands of the decision makers, which are the senior clinicians in my hospital, who also monitor my patients. That's how effective it can be. And I think earlier we heard Mr. Pai said the same thing. Technology should help us save lives. Google, we've seen how they've enhanced the AI-based algorithms to improve patient care. Similarly, I think Dozee is also, coming into this age. We need to take these solutions much further into the community. So you asked me earlier, what is the success rate of out-of-hospital cardiac arrest? Have a Dozee in ambulance, it'll work better. And that's how powerful it is. So yes, every hospital bed can be converted into a HDU bed or a monitored bed through a solution like Dozee, yes.
Thank you, sir. Thank you all the panelists. I think there are many more questions, but I think in the paucity of time, I think we'll wind up here. And we wish that we achieve zero code blue and we achieve saving more lives, and Modi has a higher number to tell Mohandas Pai sir in his next meeting every quarter. Thank you.
I would have wanted the panel to continue all night, but unfortunately we are short of time. I would request you to please stay back on stage. Can I please invite Mr. Amit Somani, who is the partner at Prime Ventures, one of the earliest backers of Dozee, and one of the earliest believers and backers of Dozee. Amit, please, could you come on stage and also present our panelists as well as our moderator with a token of appreciation from our side. If we can step Dr. Yogesh first in line. Dr. Sudhir next. Rashmi ma'am next. Colonel Shankar next. Thank you, Dr. Yatish. Thank you, Dr. Reddy. And thank you, Uday sir, as well. Can we have all the panelists and the moderator and Amit group photograph together, please? Please. I would also now like to call upon stage, before we move to our next speaker and the next session, our chief guest, Mohandas Pai sir, on the stage once more, because we have a special token of appreciation for you. There was a plan to give you a special token of appreciation, and we gave you the first token of appreciation first. That's why the memento first, talk, and then another memento again. Can I please invite you to stage again, sir? moving on to our next session. This is going to be a special session. Mission Zero Code Blues, the panel, is something that is very close to our heart. Our entire core thesis is based on Mission Zero Code Blues, enabling hospitals with the best technology available to make sure that we are enhancing patient safety. We're enhancing patient safety beyond critical care. So our next speaker is going to talk further on this topic with a decades of experience behind him. Can I please welcome Professor Dr. Ravi Mahajan sir, CBE FRCA, a visionary leader in healthcare with a distinguished career spanning national and international impact, currently serving as the Director of Critical Care Integration and Transformation at Apollo Hospital. Dr. Mahajan has previously led as President of the Royal College of Anesthetists from 2018 to 2021. With significant contributions to research, patient safety, quality improvements through collaborative system leadership, he has successfully managed, changed, and influenced healthcare policy across traditional boundaries. In recognition of his exceptional services to anesthesia, Dr. Mahajan was awarded the prestigious Commander of the Order of the British Empire, CBE, in 2022. If I may add to this introduction, and if I may take the liberty, sir, of adding something to this introduction, I would add a guru, a personal guru to the R&D team at Dozee. We benefit a lot from Dr. Mahajan and his knowledge across decades into critical care and developing the solutions further for next generation of remote patient monitoring and early warning systems and the next generation of health AI that will come out from India. Please welcome sir on stage.
Thank you indeed, Gaurav, for very nice introduction. I'm not sure whether he was talking about me or somebody else, but anyway, there we are. It's great to be here, and I really want to congratulate Dozee for where they are now after 9 years and where they're going to be. So thank you for inviting, and thank you for allowing me to share some of the experience that I had very recently while working for Apollo Hospitals of implementing remote care. And if my slides will move. I think the topic I'm going to deal with has been, you've heard the panel, and a lot has been discussed. So I'll try and consolidate and bring that together and then start to look beyond the critical care arena in terms of patient safety. So can I move the slide with this? Some declarations of my interest, which have already been mentioned. I think Mr. Pai has touched on data and how the world is going to be shrinking, people are going to be living longer. But they're also, especially in India when you look at it, and when we look at the chronic diseases, there is a steady rise over the years. And this is the data which is about a year and a half old. And as you can see, that there's a steady rise of 10 to 20% and up to even 50% in some areas in every kind of illness, any systemic illness, which is long-term illness that we can think about. And the economic burden of this, as predicted by WHO, is that by 2030, it's going to be $4.8 trillion. And you can imagine the economic burden of that sort on a country like ours, or any other country, whether it's developed or underdeveloped, is going to be huge. So something needs to be done. And lots of things being done. And as we heard earlier, technology being one of the solutions. And when we look at that and try and bring and see where technology can fit in, this is our landscape today. It remains largely up to you as an individual, if you are patient, to organize your own care amongst various facilities, whether you are at home, to nursing home, to ambulance, or to a primary hospital, secondary hospital, or tertiary care hospital. And that has its own risks and frustrations, as we know, and the inequalities in the care that is being delivered. So we imagine what the world might look like in terms of connected care at Apollo hospitals, and this is the solution we came up with, which is the comprehensive connected care. So irrespective of whether you are in the ward, in an ICU, which is connected remotely, connected home care, emergency room, or wherever in the ecosystem, you are continuously being monitored if that's what your health condition demands. Data comes to one place and it remains in one place with access to everybody else to your data. One, you have continuity of care. Second, you also have benefit of remote solutions to be available to you irrespective of wherever you are. So we had this term called comprehensive connected care, where various facilities are connected through a single digital infrastructure, and your patient care is coordinated through a command center. And I'll take you through to this video as to, and many of you may have seen it. My apologies for that because it's on YouTube and also been displayed earlier. Can I have the video, please?
Apollo, world's largest integrated healthcare provider, is setting new standards in patient safety by achieving zero code blues record through their enhanced connected care program.
So the enhanced connected care program is actually a paradigm shift in the way the healthcare will be provided in the future. The reason why we thought about this program was because we know that the critically ill patients, and we know this from our COVID experience, they don't just confine themselves to the critical care units in the hospitals. You can find them at home, you can find them in the ambulances, you can find them in emergency rooms, and you can find them in the normal wards in the hospitals. Wouldn't it be nice if we could capture them before they really became critically ill? And that's the vision of this program. Pan Apollo, we are going to be monitoring our patients 24/7, round the clock.
With that objective and intent, we are looking for all technologies available in the world, and we come across with enhanced care, which has brought down the codes significantly, almost about, in the last 200 days, I have a zero code blues, which is significant. When we take the patient on board, we'll connect the devices and we'll set the baselines and we record those things. And those vitals, whether it is heart rate, blood pressure, saturation, respiratory rate, and all those things are lively monitored in the nursing station.
If we didn't have these sensor sheets under the bed coverings, or if we didn't have the patches that go on patients' chests, if we didn't have the technology to transmit that data into the cloud and then capture it on nursing stations and in the command centers, if we didn't have this kind of connectivity, which is what technology has provided us, we wouldn't be nowhere, we wouldn't be able to start. We'd still be doing what we have been doing.
This device actually helped each nurses to save their 1 hour of time in each shift. So that has enhanced the patient care and patient satisfaction and the safety of the patient.
When patients participate in their care delivery process, they know what's happening. When we apply all these devices and patients able to see what is their heart rate, what is their blood pressure, and they also know they're continuously monitored. When they're continuously monitored, naturally they know someone is looking and monitoring me, and also with their involvement, their confidence and their satisfaction level always keep increasing.
We are covering now at least 15 to 17 hospitals out of our 70 hospitals. We only started 6 months ago, and the plan is to cover at least 40 hospitals by the end of this year. Now that technology gives us the chance of making safe care even safer, why not?
Thank you. Thanks you very much. So it's all very well, and this video was about 6-7 months. It's older, and things have moved on, and we heard quite a bit. Now, the next question I'm going to tackle here is that, does it really matter? Technology is all, quite nice thing to have, but does it make any difference? Does this approach actually enhance patient safety? We heard some anecdotes earlier from the panel. There is some published work that I'm going to refer to. And from our own experience in Apollo hospitals, now this slide is maybe 2-3 months older. We've got now about 1,600 connected beds and the rest. And what we have seen, and this is from the wards, is that once you connect the patient, I think it's very important that we manage the alerts. And once we've done that, what we have seen is that there's been 30% reduction in ICU readmissions. So patients who've come from ICU are being monitored, don't tend to get back to ICU 30% of the times. 8 to 10 early warning critical alerts per 100 monitored beds. So that's quite a significant if you come to think about it. And also 50% reduction overall in code blue calls. You've heard already in the video, 1 hour of nursing time saved per shift, improved patient experience, and we heard that from our panelists, better capacity utilization, and that's something that really helps in terms of ICU beds and their availability, and additional revenue, as we've heard from the panel. This is one study that I found very recently, and this has come from Singapore. And they looked at remote telemonitoring, whether it improved patient safety and decreased nursing workload, as we have seen in our hospital. And they came up with this is 2 years of their data from their hospital. And what they found, so if you look at the title, they just wanted to look at the decreased workload of nurses and also patient safety. And what they really found was that the rates of falls somehow, so patients having falls in the wards, that came down, as well as the decrease of mortality rate from 7% to 1%, which is quite a significant decrease in mortality, very hard and very convincing data. So that studies like that, although they're far and few, give you that confidence that maybe we are on the right track here, although more needs to be done, definitely. So this is the study that I think has been mentioned earlier. So this is Dozee study. And study suggested that utilizing continuous vital signs and therefore predicting what might go wrong actually gives you a 16 hours window before things really go wrong. So that really is important, although further research is required. But if you get, as a physician, as a treating anesthetist or critical care specialist, 16 hours of window when you can do something to things getting wrong eventually, that is quite significant in terms of provision of healthcare delivery. Another study where we heard about it earlier, where it certainly showed that the early warning scores, which have AI element to it, which is developed by Dozee, enhances patient safety and optimizes the care. I didn't have time to go through data in detail. I'll recommend that you look at these studies and see data for yourself, how convincing or not it really is. So this is a systematic review which I would like to talk about. Again, a very recent one, a review article where they put together 30 different studies all over the world. And out of those 30 studies, 3 studies documented the impact of various interventions on patient safety, because that's what they looked at. And they found that major complications were reduced, and also the mortality or the death rate was reduced overall. I've given you flavor of what is the kind of data which is emerging. They are sporadic, but they are worldwide, and they are happening everywhere. So it's not just in our patch, it's everywhere that this technology is going to go further. That's what I think. However, although we've heard about the headlines, that what it really does in terms of paradigm shift, it brings patient more to the center of the care, because patients being monitored all the time. You can detect problems early. Of course, we've heard about reduction in code blues, reduction in mortality, reduction in falls, reduction in ICU and hospital readmissions. But I think more data is required, and that definitely is true. And as we carry on, we will be collecting more data, and that will give us much better insights than just the headline figures. That will go from what is happening to why it is happening, and that will become much more crucial going forward. Also, in addition to larger studies, I think there is need for people to sit down now and standardize, because that is important. Because otherwise, what might happen is somebody does it this way, the other person, there is of course good reason why you should try different ways, but a time comes when standardization actually saves lives, and that is important, which means that we have standard structures, standard processes. Processes are important. How you monitor early warnings, how you respond to early warning score, that becomes very, very important. And I think that is where processes and outcome monitoring comes in. Clinical governance has to be the basis of what we do. It's all right to put, monitoring device, but if there's nobody to look at the alert or to respond, I think that is a burden, and that is something that we should avoid. So therefore, how we put governance structures in place as clinicians becomes very, very important for us. Of course, automation and AI and digital twin, we heard, will take things forward. But then there are going to be some legal and ethical issues we've got to be mindful of. And if we are mindful of those issues now, we can deal with them. We will have data to overcome those issues. But currently, as for example, if you don't respond to an alert, it creates a legal issue. There is an ethical issue as to, if things go wrong and they went unnoticed. And also, if your algorithm predicts something which was different to what really happened, and you've made decision based on that, I think those are the kind of ethical and legal issues we should be discussing as we take this technology forward. The technology will succeed only if we have clinical governance, ethics, and legal issues being sorted side by side. I have no doubt that we'll be doing that as the technology takes us to the next step, which I look forward to. Thank you very much. Thank you.
Thank you so much, Professor Mahajan. I now request Gaurav to please come and hand over a memento.
It's very difficult to follow up that presentation, sir. Which brings me to, we've today seen how our panelists discussed about how we can enhance patient safety, bring down code blues by the usage of technology, remote patient monitoring and early warning systems in hospitals and care facilities beyond the critical care to improve patient outcomes. Right. Sir did expand on how to stitch around a clinical governance process, being mindful of legal and ethics considerations around it. We can actually scale it up and make patient safety and make this as a new standard for patient safety, an updated standard across the board when we talk about patient safety and clinical governance and monitoring in care facilities. But why do we have to limit this to care facilities? If the technology can be simplified and can travel to home with patients, why not? And this is exactly what our next speakers essentially talks about. Remote patient monitoring, the building block of home healthcare. It gives me immense pleasure to welcome Dr. Kunal Sarkar. He's known as the architect of heart health in India, specializing in complex heart surgeries, ECMO, CABG, and congenital heart disease. Dr. Sarkar has transformed the lives of over 32,000 patients with an outstanding success rate in coronary and bypass surgeries. He currently leads as the director and head of cardiac surgery at Medica Super Specialty Hospital. Sir, I'm it's a great pleasure for me to invite you on the stage.
Gaurav, am I audible? Yeah. A very good evening to all of you. Gaurav, Udit, Sameer, thank you all for an impeccably organized event. This event only had one blemish, that late last evening, when I was walking up and down the ruins of Hampi, I received a call saying that I have to speak this evening, and that too along with a PowerPoint presentation. So amongst the ruins of the Vijayanagar Empire, I was another ruin late last evening, and I thought that what I will do this evening with you is tell you some stories, give you some snapshots that what has brought healthcare today where it is, and how do we ideate and how do we think in terms of taking it forward. When I first encountered Dozee and I was going through some of the headlines that Dozee has been making in recent times, this one caught my notice that Dozee bets on India's growing home healthcare market with new solutions. Whenever we talk about home healthcare, we talk about monitoring vital parameters. We talk about monitoring temperature, blood pressure, sleep, and pulse rate and what else. You know, big ideas happen together. Is this moving? I point towards there. So about 700 to 800 years ago, when the world was in great debate, when Galileo Galilei was sat over there, and he was taking the theory of Copernicus forward. You know, there was a great debate. Today we take it for granted. You know, Earth goes round the sun. It took humanity all of 250 years to accept this fact that it is the earth going round the sun and not the sun going round the earth. And as Galileo Galilei was putting the finishing touches to his calculation, exactly at the same time, Galileo Galilei and his friend of his by the name of Santorio, who was living in Venice, made the attempt to measure the first measurable parameter of human biology, that was human temperature. So human temperature was measured first by Galileo Galilei, that was way back in the 1500s. Exactly in the same time, we were reconciling to the idea that, look, it is a kind of heliocentric idea of the world. So it is in that earth-breaking moment that we learned to measure the first parameter of the human body. And thereafter, you think of blood, so that is when we first measured temperature, then we had the idea of Fahrenheit, etc., that was in the 1500s. Then another man, sitting somewhere in the backyard of England, he was not even a doctor, he was a priest. He had a great idea. There was a great debate those days that do we actually have a blood pressure? And is it any good trying to measure blood pressures at all? So this priest, whilst he was bored with God and praying, what he did one day was he cut out the carotid artery of a horse and he stuck a pipe in it, and there you have his assistant measuring how high the blood goes when the artery of a horse is slit. And that was the first time he used to do it. He used to do it as an experiment. Obviously some people had their horses missing, I'm sure, in the village or in the community. But that is how, after a few of these experiments, this English priest by the name of Stephen Hales was able to prove to the world that, look, blood pressure is an entity, blood pressure can be measured, and blood pressure measurement has its usage, and that over the decades that followed later on got more refined and more transformed. It is not only, the history of medicine is fascinating. If you're interested, I have a lecture on YouTube, listen to the history of medicine. But it is not just a question of people. It is also a question of events. Today we are talking about critical care, we are talking about triages, that patients will have to be separated, who is the less sickest, who is the most sicker of the patients. And the first triage in the history of medicine happened in the hands of Florence Nightingale, when in the course of the Crimean War, she had a lot of injured soldiers coming in. There weren't enough hospital beds, and Florence Nightingale is to stand and separate the hospital patients. We were chatting around here, trying to predict, the models for heart disease, trying to predict the models that, what are the factors that make us sick. The first time the modern world took any notice of things like diabetes, blood pressure, cholesterol, etc., contributing to cardiovascular disease was when Roosevelt dies. Soon after the Second World War has been won, the Roosevelt died helplessly in the front of the entire US Congress, and the US got a shock of its lifetime, and that started the first trial called the Framingham trial, from which 90% of what we know about the prevention of cardiometabolic diseases only happened because Franklin Roosevelt died helplessly in just after they had beaten Adolf Hitler black and blue. Critical care. Which event in the world triggered off the critical care as we know of today? The whole inception of critical care was triggered by one happening, and that was the polio epidemic in Copenhagen in the year 1952. It was only when we saw the polio epidemic and patients had to be ventilated, young boys and girls had to be ventilated to be saved, that we had the idea of critical care coming in. Public health care. Then we move into another era, because mind you, till about the 1930s and 40s, healthcare was a very feudal exercise. Everybody in society was not supposed to receive healthcare. Healthcare, getting a doctor, getting treatment for your problem was a very elitist, feudalistic exercise. And many things happened. You had the Bolsheviks coming in Russia, 1917, etc., etc. And then England. England had a bright idea in the year 1948. They started the National Health Service. People think that National Health Service was initiated by an act of humanity or goodness. Not at all. National Health Service was brought about by the Labour Party because they wanted to defeat Winston Churchill. Winston Churchill was overconfident. He had just boxed the ears of Hitler. He had won the Second World War. He didn't even go out to campaign in the 1947-48 elections. Then, like Ayushman Bharat in India, like your Yashaswini in Andhra Pradesh, NHS was brought on because the Labour Party wanted to throw open the great public scheme of open-ended, free-to-access healthcare to all the population, and because of National Health Service, that not only brought out a paradigm shift in healthcare in the world, but it was also gave a full stop to the political career of Winston Churchill. In India, exactly about the same era, the same time, 1947, when we become independent, look back at the Indian independence scenario. In colonial India, do you have any idea that was there any public concept of any public health care in India? Not at all. So from 14th August 1947 to 15th August 1947, there was a totally tectonic shift in our society. All these people who would never ever have an access to a hospital, to a healthcare facility, started queuing up and coming to whatever government infrastructure we had those days. Very little, very rickety, very insufficient. But it was the first time that our people had some kind of access to healthcare. And thereafter, India has been left in a confused, bipolar kind of situation. That's a story for another day, that we actually have no healthcare policy. We are a kind of hodgepodge between the public system and the private system. We get confused that are we giving primary care, are we emphasizing secondary care, are we building tertiary care? But within this sea of confusion, something has emerged, that India remains the only sort of developing economy which has developed excellence in tertiary care. There is not a second example in the world today when people with higher per capita GDP countries comes to a lower per capita GDP countries seeking solution of tertiary health care. We stand out in the world for being able to do so. In recent times, when we talk about monitoring, when we talk about critical care, we talk about all these things, probably the most cruel, the most unkind shock therapy that happened to Indian healthcare, it was absolutely cruel. We lost about 25 lakh Indians in a matter of 2.5 years. But COVID really churned healthcare in India because it was a completely catastrophic but rapid expansion of critical care. Hospitals, small, medium, large-scale hospitals had critical care. MSME units in care, which had no idea of oxygen delivery, which had no idea of critical care, overnight they had to transform themselves. It was thrust upon us, it was compelled upon us. And along with that, there was an idea of systems, there was an idea of protocols. From the central government, from the state government, protocols were coming out. How are you going to manage COVID? How are you going to manage the drug therapy of COVID? So even in a totally disorganized and chaotic state of India, for the first time, critical care, the improvements in oxygen delivery, the basic idea of protocolized medical management from the small scale to the middle scale to the large scale hospital, and along with that, there was some idea of healthcare audit. The government, after a long time, was taking note how many people were living, how many people were dying. Even at the end of all that, remember, that 25% to 30% of all deaths in India are not recorded anywhere. When we record our national mortality, we probably leave out 30% of deaths. So when we discuss advancements, when we discuss the way ahead, we have to see that what is the, Dr. Mahajan just mentioned, wonderful facts. His first slide was so insightful that we are balancing many factors right now. We have an onslaught of cardiometabolic diseases. We have galloping diabetes. People say that in the next forthcoming election, you will be given a choice of either taking your voter ID or your blood sugar in order to vote. If you're a diabetic, you will be automatically acknowledged to be an Indian and no further identity will be required. The non-diabetics can put their hands up. As Mr. Pai pointed out, the increase in geriatric ailments. Our society, our medicine was not alive to geriatric care, geriatric ailments by any chance. And what really bothers us, doctor, is as we are thinking about technology, please put your focus on one fact, that for almost 5 to 6 years, the total built-up healthcare infrastructure in India has remained static. We are finding it very difficult to leapfrog above the 20 lakh care bed capacity. Somehow, India is stuck on a few numbers. We are stuck at 80% literacy, and we cannot seem to nudge our healthcare infrastructure above the 20 lakh bed capacity. There is something holding us back over there. We are facing increasing urbanization. Now with all the technology that we are trying to bring in, do we have adequate healthcare infrastructure? I am not really a technology guy. But if our cell phone connectivity is any indicator of our technology standards, I tell all my friends in the cell phone industry, I hope you are not critical care doctors, because with the amount of call drops we have, if that was the amount of drops you had in your critical care response time, you would be thrashed up by the patients 5 times a day. So is our technology up to that limit? But yet we remain to be the country who has lifted about 200 million people in an era, has been lifted out of poverty. And as once again been mentioned already, that is in the first time of our recorded history, we are having a life expectancy of 70 years. So this is a mass of contradictions in which we are having to live. Will this move? Hello? Can you get the slide to move? It loves this one, it won't move.
Can we move the slides? Next. Yeah.
Next slide, please. Next slide. Right.
Yeah.
Now, when we talk about home health care, please spend half a second and remember that health care actually started at home. Hospitals came much later. Because here you have a picture of Leonardo da Vinci dying. Where did he die? He died at home. Our great Rabindranath Tagore, he would not go to the hospital. He had his prostate operation in the corridor of his house in central Calcutta. And he succumbed to sepsis 4 days later. So home care actually started at home. It was only in 1830s when the first intravenous medicine, first intravenous therapy came up in Edinburgh that people felt the need for going to the hospital.
So what we are trying to today is actually to rediscover history. Home care actually started at home. Then came the next 200, 300 years when people were told that you actually need to get to hospitals for better treatment. And now we are trying to tell people that, look, you do not need to be in hospitals for many a treatment. You can be effectively, efficiently monitored at home. And this represents a kind of taking the clock back. Some ideas, some thoughts about when we talk about implementing home monitoring today. It is a matter of both individual and institutional acceptance. The technology is here. Our friends like Mudit, Gaurav, their team will tell you. The technology is here. But when we apply the technology and take it to an individual, it has to be found to be acceptable to the person. And as our friends from all our hospitals across the country discussed, the institutions will have to accept it. Early detection, prevention of hospitalization, and what I felt is very important is, I visited some of the units in the United States recently where they were using the transformation from the non-invasive monitoring from hospital or care units back at home. And there they came out and they came up with a very interesting concept. You see, in the United States, people are very allergic to wearing devices. You know why? Because these devices were actually put on people who are out on parole. So in India, if we had started putting devices, say in people in our MLAs and MPs, then probably 30% of the legislature will be wearing these devices because half of the legislature is probably out on paroles. So over there in the societies, there was an instant inhibition about the fact it is not one of these hideous devices that we are wearing. So you will see that there were, if you leave Dozee apart, there were many other bulky devices that people were wearing at different times, and somehow they did not find, they were not hugely popular with the people over there. And the technology requirements, when we put a device at home, we will have to make it married to the level of technology that exists in that place. Their availability of their connectivity, their broadband, will the data go through their cell phone? How will the data be uploaded into the cloud? And it is high time, I think the brilliance of the technology that has been fabricated so far, I think we have to have the confidence to implement it. Mudit, Gaurav has discussed quite a bit with us that how the patient's data is going out from the patient, getting stored in a cloud. But probably the greatest challenge that the family, both the medical people who are involved medically and technologically, people who are involved with Dozee will face right now is, have we got smart enough algorithms to manage the large number of data, the signals, the warnings, the each spark points that will be generated by this enormous volume of patients who are being monitored? And how do we cope with it? How do we cope with the data? Because there will be what is called in medicine a sensitivity is to specificity conflict. If you have a tremendous bulk of data going, huge bulk of data, it will be extremely difficult to take out specific data out of that. And if you have too little data, you will end up into the sensitivity problem. But there is no other way. There is no other way, but the game has to be played in order for us to learn this game. So we have to get better in this data interpretation, data interface. I am already sure that the technology that our technological brains have produced in the background, I'm sure it will be good enough, but it will require a lot of improvement.
And we have to open ourselves to one fact, which is probably this changeover cannot be very abrupt. There has to be a machine to a human interface at some time. Probably in the beginning, like you have in the various helplines that we ordinary people encounter every day. Whether it is with a bank, whether it is for an airline, whether it is for our mobile phone company, there will have to be a technology human interface that is going to take it through. Because especially for anything to do with monitoring, for anything to generate an alert and somebody from a command center to respond to the person or the person's family about it, I think a generous amount of human interface in the beginning will be required. And as time goes on, how much of the human interface remains and how much of the refined AI capability takes over, I think will be answered by time as time goes on. Institutions, as my friends have already discussed today, anything that improves outcome, improves revenue, cut costs, they will take it up. But the institutions, it is not only a matter of top line and bottom line. In between the top line and bottom line is very important what happens in the middle. And we as clinicians are looking forward to this to technology like this. Why? To increase productivity. I'll just leave you with one data. Just look at this data. That India today is put in the lower middle income country who in a matter of next year or two will become a high middle income country. And if we are really a kind of higher end of a middle income country in the next 2 to 3 years' time, this is our underproductivity. I have just taken cardiac surgery to be an index because that is one area I know a little bit about. So if you look at magnitude terms, it is something like comparing the GDP gap between India and China. As we improve, even if China grows at 1%, 2% per year, the GDP gap stays. So similarly, we are not only here to be differentiating, we are not only here to improve our margins, but we are also here to improve the processing capacity of our infrastructure. Because this is a data that tells us that given our income, given the national financial resources, given the disease burden we have in India today, we as clinicians are underperforming. If you translate this data to any other field, if you translate this to orthopedics, if you translate this to general surgery, if you translate this to gynecology, for each procedure by procedure, you will see that we have a median gap of 20 to 30%. And faster processing of patients, improved outcome, improved monitoring must help us to bridge this productivity gap. And needless to say, this has to fit into our economic module. India is a 30-30-30 market now. We have a 30% normal insurance, 30% government insurance, and 30% of the middle class who are in a precarious position, who are either non-insured or semi-insured. So we have to fit into there. And it is a matter of improving our productivity. It is today a matter of improving our outcomes, and it is sweating our capacity much more. Because given the number of insured people we have in India today, with our population of about 140 crores, the number of insured people in India today is about 3 times the population of the United States. I am taking out people who may not be insured. So if you take that into consideration, I would implore all the healthcare thinkers to go back to the board and quantify. This year, India would be doing the equal number of cardiac surgeries as the United States, which is around 250,000 a year. But I was telling our association that we are doing an equal number of cardiac surgery at United States in spite of having 3 times the captive population. So we have a lot of introspection to do today. It is not a question of we not having disease. There is enough disease. There are people who have the problem, the people who are already got the financial amenities to have the treatment. It is our limitation to detect. So Indian healthcare today has one great limitation, and that great limitation is the limitation to detect, and that is what our systems like this must now be building in and looking forward to. In the global scale, it is also absolutely relevant. When we improve home monitoring, when we improve non-invasive hospital monitoring, it will be relevant in the United States, in Europe, in Asia, because every part of our economic geography in the world has its own problem. US has 17% of the GDP towards healthcare, but one of the most modest outcomes. Europe's governmental finances are stressed, and Asia today is struggling to give healthcare to its large population. So the future, whether it is for non-invasive monitoring, whether it is for home care, will be a very strategic alliance between the science on one side and the strategy on the other. And we have to ask ourselves the question that what are we actually wanting to do? And once we have clarity, once we have simplicity in the idea, I think that this kind of product, this kind of service has now, our society is crying out for it. We have to be brave, we have to face the brave new world, and this has now got to be implemented. So to our teams and all our young members of Dozee, I say that your job today, you are like getting up the peak. You know, you've done a lot of hard work. You know, you are probably somewhere in the second or the third base camp towards the peak of the Everest. And given your dedication, I am sure you are going to get there. So for a very average, stupid Bengali like me, when I come to the city of Bangalore, which is now the knowledge capital of India, I leave you with one story. It was in the month of July of 1893 that 2 people met on a ship. And one of them was a young diabetic, extremely sick, in his late 20s, on his way to address the World Parliament of Religions in Chicago. And the other passenger in the ship was this gentleman of the left, Jamshedji Tata. And Jamshedji Tata had a couple of conversations with Swami Vivekananda on the same ship. And after conversing with Swami Vivekananda, Jamshedji Tata made one remark, that India has to make original science, India's research has to reach out to the world, to the service of its own people and to the global community. And I'm ever so happy to say that when I see the effort and the enterprise of people like Dozee and so many, many other participants of the knowledge economy in an environment of Bangalore, I think that the great dream that was dreamt in July 1893 has probably come to some fulfillment. Thank you very much. Good evening.
I request Mudit to present Sir with a very small token of our appreciation. Sir, every time I hear you speak, I learn something new, a unique perspective to look at home healthcare through history and through contemporary scenarios.
So, sir, it's only poetic. your last slide, given that, remember where we had met the first time? I met sir in Chicago. I had a pleasure of listening to his talk in Chicago in a RP conference, and so glad he is here, shedding his wealth of knowledge again with all of us. Thanks a lot, sir. Thank you, sir. Can I help you with that? Yeah. Hey. Great. So here we are. I think we have heard the wealth of knowledge coming from likes of MDP, sir. Why it is economically, why as an economy health monitoring is so important. We heard from Kunal Sarkar, sir, that why it is important clinically and also, in other dimensions as well. So it's paramount. Let me share a small story about, the genesis of this product, the Dozee Shravan in itself. As you would have likely known, the name Shravan, and you have heard this name, right? The name Shravan comes from Ramayana, is inspired from there, from a story of how one young boy named Shravan goes out of the league to ensure the last wish of his dying parents. He's the gold standard of parent care. And I think parents have given us so much that they are worth everything and anything that we can do. Let me share a small story. Now, as we are going global, right, we are all seeing here, my trips to US, my trip to other parts of the world have exponentially increased. Whenever I am outside, one constant worry which is there is, how is the family doing? Especially the parents. I know they are aging. I know that, they are not in the best of their health while they used to carry me on their shoulder. So while I should be by their side, here I am traveling the world trying to make Dozee a global company. I know that, they see that dream in me as well, and then they support me full-heartedly over there. And that's where I felt the need of Dozee the most. Actually, I'll share another story of one fine day, especially in my last trip to US, I got a notification from Dozee, because my parents are using Dozee for last 5 years, nearly about that, my mom's respiration rate has suddenly increased. I got in touch with her. I understood that it's only a cough. She had a mild fever maybe, and I was relieved that, it is only the mild fever over there. But the point is that when you are away, that anxiety is even more. And it is not singleton. Samir, who is a very senior member of Dozee, joined us nearly about 5 years back. He joined Dozee because of this very concept. His dad used to be a CKD patient. I'm saying used to be because unfortunately we lost him to COVID. But he used Dozee 5 years back to monitor his dad's health. And he has been NRI for 13 years. Now, being an NRI, he always and constantly lived in that anxiety that, how his dad is doing. That is what led to him getting here. And he did so much that he ended up even joining Dozee as well. And we really, Samir, if you can just stand up and wave, right? Here we have Samir. This speech was originally supposed to be given by Samir, right? This is his dream, I know that. But I'm filling in for him, and I hope I'm doing a good job over there. But imagine how many Mudit, Samir, and Gaurav are there. How many of us are there, right, who are constantly away. We can't be near our parents, but we want to be with them. We want to ensure that they are given the best care. And that is exactly what Shravan stands for. So can we have the film played?
Yep, my team is actually working on the updates as we speak, and we should be all done by tonight. Hey, I'm sorry, Steve. Can I call you back? Ma? Itni late? Come on, pick up, come on, pick up. Yes, doctor. माँ कैसी है?
She's fine now, Abhishek.
Emergency से निकल आए?
Yes, but it was a very close call.
Oh, what do I do? At least everything seems okay. अरे यार माँ भी ना.
हेलो.
मॉर्निंग माँ, कैसे हो? सब ठीक है ना?
मैं ठीक हूँ. अरे कल रात को 1 बजे कॉल किया था, तब तक तो मैं सो गई थी. सब ठीक है ना?
हाँ, वो आपकी मिस कॉल्स देखी and it was pretty late over there, so I got a little worried. And उसके बाद आपका मैसेज देखा. अच्छा ये बताओ, Dozee shows your blood pressure is a little higher than normal. आप दवाई तो टाइम से ले रहे हो ना?
अरे तेरे को बताना भूल गई, मेरी तो मेडिसिन खत्म हो गई.
क्या माँ? You could have told me earlier ना? आपको Netflix याद है लेकिन मेडिसिन नहीं. मैं अब भी मंगवा रहा हूँ, आप प्लीज टाइम से लेते रहना.
मेरी जान, खाती हूँ तो खत्म हुई है ना. वैसे एक बात बता, कल मैंने 2 गुलाब जामुन भी खाए थे. तेरे दोजी ने नहीं बताया तेरे को?
माँ, आप Now I'm going to have to call the doctor and tell him to just keep you at the hospital.
हेलो, तू जानता है, no hospital can contain your माँ.
So friends, here we are to such a beautiful bond of parents and kids. So we have this solution now. We have this solution which is designed for elders. It is not going to change the way they are. It is going to be it is going to be under their mattress, so it is not going to help them to wear anything. So it is designed for them, total privacy, as well as it comes with a subscription plan in which it can be connected to the hospital systems that Dozee has today, and thereby helping the managing an emergency situation as well in case that happens. And that's where I now want to invite on stage all the inspiration behind this product. I want to call on stage MDP sir, please come over. I want to call on stage Kunal Sarkar sir, please join us. I want to call on stage Mahajan sir, please come as well as our guest of honors. I want to call on stage my mom, dad, Gaurav's mom and dad, and Sameer's mom. Please join us. Please join. Acha. All right, Mac, can you begin? Yes. So is Sameer's mom, my mom and dad. Let's start, Mac. All right, let's be a little behind. Let's be a little behind. This is the moment we all waited for. So are you guys ready? So Dozee is coming closer. That moment is coming closer.
Sarve bhavantu sukhina. Sarve santu.
So I'd like to invite all the dignitaries to hold the. Sir, please. Sir, aap. Aye. MDP sir. So your blessings are required.
कुछ कर दिखलाए एक ऊर्जा से विश्व जगाए इनोवेशन का परचम
Let's get along the product to click a picture. Sir, please come. Also like to invite, so first set of Dozee boxes we have reserved for our special guest. So can I ask Samir to present this box to his mom? Gaurav, please do the honors for your mom and dad. MDP sir, originally I had Pranav for doing that, but I am here as well. Come here. Sir, can you come here? Yeah. No, this for you, sir.
Sarve bhavantu sukhina Sarve santu niramaya Sarve bhadrani pashyantu Ma kashchid dukh bhag bhave
Thank you. I also want to announce that we are also going to Marvin sir. Great. I like. Yes. Thank you. All right. All right. I like everyone to please get back to their seats. And thanks a lot for joining this. We have another action-packed launch after this. So I would also like to announce that, Dozee, Shravan, we are going to be launching along with our partners in US in Mediglobo. So I think my mom wants to say some 2 lines, so please grace the stage.
Thank you so much, Dozee, for the honor, and congratulations for your remarkable success. I know this is the result of your collective efforts. So I would love to express my feelings through these lines. For you, Team Dozee. ये मचलते हैं तो तूफान मचल जाते हैं, ये उबलते हैं तो भूचाल उबल जाते हैं, इनको तुम बदलने की कोशिश न करो ए यारो, ये बदलते हैं तो इतिहास बदल जाते हैं. So all the best, keep rocking, keep shining. I know you will create the history. Thank you so much.
Thank you. So all of you who were doubting at my lyrics, here they come from. And no, in fact, my mom's Hindi is amazing. I've learned a lot from her dad as well. And coming to the absolute grand finale now. Can we load the Dozee VS launch sequence? All right. Just great. So we did talk about the home monitoring and need for that. But I want to go back one step again, right? Let's go back to where all it started from. What were those landmark moments in the history of Dozee? And I think we are right there again. We have just seen one, but today is a special night because it's not one, it's two. So let's see. Next slide, please. Do we have a clicker? Okay. So in 2015, I met this very happy Can you hear me? Right, I'll use this. So in 2015, while I was still busy with race cars, making it faster, one life-changing event happened in which my uncle, right, had a very serious, very serious condition. Because of that, he had to go through kidney transplant. Because of that, we really, nearly lost him. And that really shook me that, here we are building and making race cars faster. We're using all the analytics in the world to make cars better. But here we have, healthcare which is still there that, nurses, the protocol is that, manually monitored vitals are being taken. And that's where both of us got along. We got a purpose that we want to make 1 million lives. So I think that was our first landmark moment. The second moment came when this one came. He's still there. He is a very naughty dog. His name is Pi. And he did one thing. He would just chew off everything that would come in his plain sight to save Dozee. So we had not envisioned Dozee as being contactless. We had made Dozee as a sensor sheet that goes above the mattress. But to save it from him, we kept it under the mattress. Because that happened, and we forgot to switch off the monitoring, we were still getting all the readings. And that's where the eureka moment came for both me and Gaurav, that, hey, we can make it contactless. So, coincidences and accidents happen. You just need to be there. And because we were there, Dozee became contactless. And we thought that imagine what kind of experience we can deliver. But does making contactless itself is enough? Answer is no to that. Next, we started our journey for trials. That's Gaurav in front of Niman's Human Sleep Research Lab. We started validating our product against polysomnography. That how accurate are we, how accurate are the algorithms and all of that. And we kept on getting better and better and better. And our goal was one. It has to be as good as ICU grade equipment. It took us almost 1 more year to get the science perfect. And now we had a technology that can place under a mattress, monitor heart, respiration, as well as ICU grade monitor. In 2019, we got our first customer. At that time, Dozee, as Dr. Sarkar also said today, Dozee is actually, the first customers were home customers. So Dozee went home first. And while the luck had it, in 2020, we had something that changed the entire healthcare ecosystem. COVID, right? And because of that, the awareness index in hospital increased manifold. The same set of hospitals who were saying that, hey, we don't require any kind of technology to monitor, were now calling us in that, hey, I think you had shown us something that monitors patients remotely without contact. We really require that because our staff is getting infected right now. And that's where we got our first break. And at scale, we got it in IGGMC Nagpur. In IGGMC Nagpur, we converted at a large scale all the beds into continuously monitored bed. We had set up a remote monitoring cell over there. And at that point, at peak, the nurse to patient ratio was 1:40, at times even 1:60. And in these conditions, we helped the hospitals manage patients and not just manage, do a record number of successful ICU transfers and all of that. In fact, that became our award-winning service. And I'm really proud of the work that we did during that time. But IGGMC was not alone. Once we understood that, we started working with defense. We started working with multiple state governments to now drive transformation at scale. We worked with more than 100 hospitals now. And now we knew that, this technology, when implemented at mass, at scale, can save lives, can bring nursing efficiency, and can improve outcomes and thereby save costs as well. And then came the moment of 2022. From this very stage, we understood that patient safety is not to be restricted in 1 bed or 2 bed. It has to absolutely reach each and every patient bed. We launched our campaign called Her Bed, Dozee Bed. And not just that, to back it up, we also launched a product then. That is called the Dozee NX, which you have right today, and a lot of our hospitals who are present here are using it today. This change, right, over there, we had our first set of our customers who were Her Bed, Dozee Bed hospitals. I'm very glad to see Dr. Yatish, Dr. Reddy, who are very first believers, Dr. Uday, right, who are very first believers in the concept of Her Bed, Dozee Bed. And once they did that, we started seeing constantly, like how you saw in Dr. Mahajan's presentation as well, that how the technology is significantly bringing down the code blues. Not from one hospital or two hospitals, continuously we started getting from all of our hospitals, especially and typically those hospitals who were Her Bed, Dozee Bed, that our code blues have started to reduce drastically. And that's really what we made our mission. In fact, we launched our Dozee anthem today. There you have a line there. Our mission is to have zero code blues. We made that our mission. And with that, we also knew that, the world is our stage. And we also got our US FDA as well during that time frame. So here we are today. We have a technology that's proven. We have a technology that is now having international grade accreditation. And we have a track record now of a technology that improves, that drastically reduces code blues, that improves nursing efficiency, and at the same time without compromising patient experience. And we now want to take it even a step further, even a notch further, all of this. So code blue, when we are telling, we kept on hearing from our customers that Dozee beds code blue have reduced, the ward bed code blues have reduced. But how about in corridor? How about when the patient is in the washroom? How about when the patient is not on the bed, when the patient is actually ambulatory, right? Second thing, very important that nurses are the ones who adopt this technology and deliver the impact. How can we make their lives easier? Won't it be nice if there was an interface where nurses could actually interact? Won't it be nice if a nurse, rather than has to type in something or write down something on EHR or EMR, can use the conversational AI to just tell the note which is there and it directly goes into the discharge summaries and all of that? Can we not make their job even easier? Can we not challenge them one more time? And Dr. Sarkar did ask us and MDP sir as well, that challenge ourselves, redefine healthcare. And that is exactly what we have our next product, which is meant to do that. Let's look at Dozee VS now.
I have changed the BP medication for the patient.
Let me ask you one more time, is this it? All right, something is happening.
सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत्
निकट कुछ कर दिखलाए एक ऊर्जा से विश्व जगाए भविष्य का पंच उजल आए भारत का गौरव बढ़ाए निश्चल समत्व समर्पण से केसरिया रंग में आए शो हो जाए हर बैठ हिलते आए डोज़ी बैंड शो हो जाए हिलते आए
We are on a mission of zero code blue. It ought to take the best in me and you. Na dare, na ruke, na jhuke, na thake.
So when we say ambulatory, right? Do we mean it? We do mean it, right? That's my data that you see over there, right? So that's Dozee VS, not just in the bed now. It's right there, even when the patient is outside. I'm doing quite good now. Looks like frozen, but still doing all well. Thanks a lot, guys. And we are good. I would like to invite all the dignitaries. Can you please come on the stage? Let's do one picture, and then we are done over there. We'll call it the night.
So can we have all our speakers from today please come on stage?
Please come, please come. So everyone, all the healthcare leaders.
सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत्
Thank you. Thank you. Thank you. Thank you. Thank you. Please come. Please come. आप आइए sir, you are the one. I think customers are in the center, right? Customer centricity is the key.
To all of you who've been patiently watching from home, online, thank you for joining us. We'll now be ending the live stream, so thank you so much.